Open, you switch.
All right. Okay. Good afternoon, everyone. We're going to start. Yes. So I will be the chair for this session. I'm Georges Perrin, technical advisor at World Health Organization in Afro, Congo Brazzaville. The title of the session this afternoon is Why Do We Need a Renewed Focus on Stigma and Discrimination in the Health Sector? We have a brilliant panel today with 5 panelists and a speaker from Geneva, WHO Geneva. So a quick background about the session today. As you know, stigma and discrimination have remained persistent barriers to effective HIV programming for the 40 years of the HIV epidemic. While progress has been made in addressing stigma and discrimination, it is still variable and fragmented. Stigma and discrimination have been shown to increase vulnerability to HIV infection and affect both quality of life and treatment outcomes for people seeking HIV services. All these factors including mental health issues, employment issues, compromise access to and utilization of health services. This satellite this afternoon will highlight and share examples of good practice and progress in 3 priority areas that are essential to ensure health system ability to provide dignified, equitable, diverse, and inclusive services. The 3 priority areas that we'll brainstorm today is 1, placing people in the center, 2nd, ensuring quality of services, and 3rd, promoting enabling environments. So now I will going to introduce the panelists, and I will ask our guests today to do the presentation of themselves. Omar, let's start with you.
Thanks very much, George. Good afternoon, colleagues and friends. I'm very delighted to be here. My name is Omar Sharif, and I'm currently with the Global Network of People with HIV. I'm originally from Indonesia, but now based in Netherlands. So really excited to be part of this important discussion. Thank you.
Good afternoon, colleagues. My name is David Mkandla. I'm happy to be here. I'm coming from an organization called ICASA in South Africa. That's where I'm based. And within ICASA, I'm responsible for community system strengthening. And one of the key interventions that we're doing as ICASA is community-led. And we're going to talk a little bit about that today. Thank you.
All right, Dr. Masego.
Good afternoon. My name is Dr. Masego Gilbert. I'm a senior technical advisor with FHI 360, working on HIV programs and key population programming. And thank you so much for joining this session.
All right. Beata.
Good afternoon. My name is Araba Mokando. I'm a nurse working with HIV people, and I'm from Ghana.
All right. Barry.
Hi everyone, my name is Barry Didier Nibogora. I work as a policy specialist with the UNDP regional office based out in Pretoria. And happy to be here, and thanks for attending this session.
Thank you.
So there are some drivers of stigma, which include fear of transmission, lack of awareness about stigma. So health workers can behave in a stigmatizing way without even knowing that they really stigmatize the patient. So attitudes, and also importantly, institutional environment, and also more largely, of course, it's also policy and the laws. So this all leads to manifestation of stigma in the health sector that includes avoidance, refusal to provide care, and so on and so on. And this all has an impact on all the components of HIV response and preventing us from reaching the global targets. But important to understand that these are immediately actionable drivers. So, I mean, there are things what we can do to address the causes, those drivers of stigma. So there are different approaches published in the literature. Okay, so, and importantly, what you can see in this, sorry, it runs too fast. Importantly, these are the strategies which include provision of information, skills building activities, participatory learning, and also contact with the stigmatized group, empowerment approach, and structural policy change. So these are all key strategies, and they can be used in different approaches. So one is the total facility approach, where I mean, we'll hear a little bit more about how this approach was implemented in Ghana from Roberta, and so you'll hear a bit more about it. And we are also going to publish a web story on WHO webpage about it, and some other approaches. I will not go into details. Globally, there's a lot of commitment. There's the global AIDS strategy, the political UN political declaration, and we all know about 10-10-10 targets. So, I mean, there is a basis, and there is a way how to argue for the importance. And also, there are lots of initiatives, global initiatives, especially by UNAIDS. UNAIDS with the partners and with GNP Plus is leading the global partnership to eliminate all kinds of HIV-related stigma. And so there is the map, and more countries and more countries are joining this platform for joint action. And WHO has a role in this, within this global partnership, to address stigma in the healthcare sector specifically. Also in our global strategy, we are moving towards more integrated care. That means we are trying to address HIV, hepatitis, and STI, and other health issues together in a person-centered way. We had a series of consultations with experts and communities and so on. So we kind of identified the areas for work for WHO that will include development of the guidance. This is part of WHO mandate. So we're going to develop a technical brief which will synthesize and disseminate good practices and also tools and frameworks in a very practical way. So it's not going to be a very theoretical document, but something that really needed. And we take it very seriously, and we'll tell you a bit later about this future product. So we also are starting to facilitate country exchange, country support, and really how to say, amplification of good practices. And our third area of work, we are going to work with future health providers, so trying to collaborate with medical student associations and with the health professional societies to help to shape the curricula and training. So the technical brief, so that's a very brief structure. So it will include background and describe interventions, and we were planning to structure it around 5 priority actions. But then after the consultative process, we made some further decisions. So last month we had the online feedback collection, and we got lots of responses from different actors from all the regions, from health providers, from communities, from researchers. And that was real endorsement of the need of this guidance, which will amplify the examples of good practices, provide training tools, support involvement of the community in the monitoring of stigma through the community-led monitoring and other methods. And so basically this is that. And in the end, we see that there has to be like 3 priority areas which have to be addressed simultaneously if we want to reach a real impact. So one is the people in the center. That includes engaging with the communities, empowering community-led monitoring, and also promoting quality of life for people affected or living with HIV. The quality services, that's also the whole range of interventions that including trainings, supporting practitioners, also supporting practitioners who might face internalized stigma or may face stigma because they are working with people who are living with HIV. So they're building capacity and so on and so on. And also, not last but not least, promote enabling environments, which deals with the policies, but also law reforms. That's my last slide. That's kind of our next directions for our work. So we continue providing country support. We will develop tools for social media and distribute as WHO. So there will be a living toolkit of educational materials for healthcare providers, future healthcare providers. And we're also planning to extend this work beyond HIV, also addressing intersectoral stigma, not only related to HIV, but also stigma related to key populations, mental health, and other health areas. So that was in brief, and thank you. This is a photo from Ghana, from our hospital. Thanks for now.
All right. Thank you, Anton, for this brilliant overview about stigma and discrimination in healthcare settings. And now we're going to have this open conversation with our panelists. So I'm going to ask some questions to our panelists, and they will share with us their experiences and their lessons learned about the work that they are doing in stigma and discrimination. So my first question will be addressed to Omar. Omar is working with GNP+, the global network for people living with HIV. And my question to Omar, what are the key findings from the most recent HIV stigma index report and others that transfer to action? So maybe you could explain as well what is the HIV stigma report. So what are the key findings from this report and others that transfer to action? Yes. Over to you. Yes.
Thanks so much, George. And good afternoon again. I think before I'm sharing key findings on the latest situation of HIV-related stigma and discrimination in healthcare setting, allow me to briefly, describe what is PLHIV stigma index. So PLHIV stigma index is a community-led research that was done and implemented by people in the HIV community. It is a very robust scientific process. So we're using a very strong scientific approach in terms for us to implement this research. And the report that we just currently completed is the global report, which include data sets from 25 countries. Half of the 25 countries is in the Africa region. And we have more than 30,000 PLHIV participating in this process. So this has been our key intervention in terms of not only documenting the evidence, but use it for advocacy purpose. So that's a stigma index in a nutshell. So we just recently completed the first ever global report on stigma index, because stigma index has been around for more than 15 years. But this is the first time we were able to compile those data sets and have it, published as a global report. And there are two key findings on healthcare setting that I wanted to share with everyone this afternoon. And actually, we from GNP Plus, we give the privilege to WHO because this is the first time we talk about our key findings from the global report. So there are two key findings that I wanted to share when it comes to stigma and discrimination in healthcare setting. So our report shows that 1 out of 8 people experience HIV-related stigma and discrimination from healthcare workers when they're accessing HIV care. When it comes to non-HIV care, the number double. So for HIV care, it's 13%, or 1 out of 8 people experience stigma and discrimination. For non-HIV care, it's double. It's 24.9, almost 25%. So clearly, there's a huge issue, which I think we all know. And to add to that, findings when it comes to experience of key population living with HIV, the number is even higher. So among transgender living with HIV, the number is almost 32%. Among sex workers, it's almost 30%. And among people who use drugs, it's 27.8%. So this is clearly a solid evidence to showcase that there's a huge issues in terms of the quality of service in the health facility. So this is something that is not a new thing. I do feel that this is not a new news for everyone who's been involved in HIV response. But this report solidify those information that we have been hearing so much. And this is really boiled down on how the service being delivered in terms of the quality. What also important is we always talking when it comes to attitude or behavior of a healthcare worker. We always think the answer is education, to educate them, to increase their knowledge, and so on. That might be the right intervention 20 or 25 years ago. But I think it's time for us to look at a different intervention, because we cannot keep on doing the same thing and expecting different results. And we all know that knowledge doesn't translate directly to beliefs, because stigma and discrimination is about beliefs. A lot of people fully aware of HIV transmission, of HIV risk, but that doesn't mean they won't have a stigmatizing or discriminatory attitude. So it's beyond knowledge. So this is a very key point that we all need to discuss together and find a solution together. I'm going to stop there.
Yes. So thank you, Omar. So before moving to David, so this report will be available next year or to the public? Yes.
We will formally launch it tomorrow.
Yeah.
And we will have access to the full report. So I can share with George probably the details of our events tomorrow.
Mm-hmm.
And I'm expecting everyone to be there when we launch the report tomorrow.
All right. Thank you, Omar. So now we're going to pass the mic to David. David, World AIDS Day is about, the theme this year is let the communities lead. So we know the importance of community in addressing stigma and discrimination. So my question to you, how can community-led monitoring be used to monitor the quality of HIV health services in terms of providing stigma-free care? So it is a double-fold questions. How can data from CLM be used as well to inform improvements in HIV and other health programs? Community-led monitoring. I know it is your field. Yes.
Okay, thank you so much. And thank you so much for the question. I'm going to talk to you from the lessons that we have seen from our community-led monitoring program that NACOSA is implementing in South Africa, in one of the districts called Westland. We've been implementing for over 2 years now, and there are very critical lessons that have come along the way of the questions of saying, how can we use CLM to monitor the quality of services in the healthcare settings? One thing that has come up very clearly from our program is that we can use CLM to engage key populations as field researchers or as data collectors. That is very important, that as key populations, they are able to collect data as members of the community. And they are also able to help define the indicators that are being tracked at various levels, especially in the facilities. And that is very important because it also brings them closer to the healthcare providers in the settings. So with that kind of closeness, they are able to collect data and also interact with healthcare providers in the facilities. The second thing is that we can use CLM together with key and vulnerable populations to create user-friendly tools, such as surveys and checklists to gather information. Many times, there are survey forms, there are tools that are quite difficult for key and other priority population. So community-led monitoring gives us that kind of an opportunity to work together with key and other priority populations to develop tools that are culturally sensitive, to develop tools that recognize the diversity of key and other priority populations. The third thing is that we can use CLM to strengthen the collaboration between Department of Health or healthcare providers and the key and other priority population themselves. And this is very important. What we have seen is that it has given the program an opportunity, for Department of Health or for facilities to understand what CLM is. Sometimes there's fear when you talk about CLM in facilities. They think you're coming really to monitor them. But just for them to understand that the process at the end of the day will benefit the facilities, will benefit the key and priority populations themselves in terms of the uptake of services. And the other issue is that it makes it easy to develop capacity of healthcare workers in terms of how to handle certain situations. One of the lessons that we got from our intervention was that there was limited capacity to manage GPV cases from the facility. And in terms of dealing with that, we had to work together with the department to come up with a training package that meant to build the capacity of the nurses, management in the facilities on how to manage GPV, how to document and how to put all the data together. And there were a lot of other issues because we realized that GPV data was sitting on different forums, and you wouldn't go to one place and get all the information around GPV and get it at once. And this was even more important for the key and vulnerable populations themselves that were data collectors. And they say our data collectors were like our sex workers, our adolescents and young people, people who use drugs, and the LGBTI community. So you find that our data collectors were coming from this range of key populations, and we're looking at 14 facilities, which are like our key facilities that we are looking at for now. And then the fifth thing is that CLM provides an opportunity to raise awareness about the importance of stigma-free care in the facilities. Because of the communication that is there around the findings from the data, it is possible to raise awareness. But also, it also provides an opportunity to advocate against discriminatory laws. There are some very troublesome and worrying discriminatory laws against your people who use drugs, against your sex workers. So CLM provides that kind of opportunity to advocate at different levels. So in terms of using data, CLM data, we can use this data, CLM data, to develop policy briefs, which is where we're going as NACOSA. And when we're talking about policy briefs, we're talking at different levels. Policy briefs at sub-district level, policy briefs at district, at provincial level. So we can use this data to develop these kind of policy briefs and also strengthen the accountability processes and mechanisms. We can use this data to empower communities in terms of how they make decisions. Because remember, they are part, especially your key and vulnerable populations, they are part of collecting the data, they're part of data analysis, and when you make feedback to the communities and you're giving this kind of data, it provides an opportunity to make very good decisions because it's decisions that are evidence-based. But also, it allows communities to own data about their own health. I think this is very important. Situations are different, but community-led monitoring is getting us to that space where communities are able to own data about their own health at various levels, at a local level, at a district level. And this is very empowering and very, very important. And it requires an enabling environment. And it speaks to the theme of the World AIDS Day: let communities lead. And if they've got data evidence about their health in their own settings, they're able to lead, they're able to make meaningful discussions. This data is also able to show us where gaps are in terms of service delivery. And our experience is that we've identified gaps in particular facilities. So you don't generalize and say there is stock out in the facilities. You're talking to specific facilities to say at facility A and B, there is this kind of stock out. And when you are engaging authorities, management, Department of Health, you're talking about a particular facility, and they're able to get there and deal with the problem without generalizing. Because what we're seeing was that sometimes we generalize and say stockhouse, and management will start fighting with you. You said, no, there is no drug stock out in this district here. What do you mean? And it becomes problematic. But our lesson is that through CLM, we've been able to go to particular facilities. And the department has been very appreciative of that we're pointing them to where the problems are, the bottlenecks are in each and every facilities. And the facilities are not homogeneous in terms of the problems. You will see different problems and be able to deal with them differently. And the other issue is that it gives us the opportunity to always interact with the communities, and the communities can give some guidance on how we equip some of the health care workers with important skills around providing stigma-free care. And my last point is it helps us to improve resource allocation at a sub-district, at a clinic level, at a sub-district level. It's very important that resources are allocated towards areas of greatest need. Thank you.
Thank you, David, for your extensive presentation and explanation about the role of the community-led monitoring and also the importance of the CLM, not only in monitoring the quality of services, but also in advocacy, as you said. And I think it is very important that we not only mention the term that the community lead, but we took it in action. So thank you. So now we have another priority area in stigma and discrimination issues, that is ensuring quality services. And Dr. Masego, can you please share with us the experience of integration of the KP health services in the public health facilities in Botswana, and what are the crucial components of success from your experience in Botswana?
Thank you, George. So allow me to take you back to the common drivers of stigma that was shared by Antons, that are in most cases, stigma in healthcare settings is due to negative attitudes, beliefs of the healthcare providers and the biases they have, lack of awareness of why KPs should be provided with tailored services, the inability to clinically manage or provide comprehensive quality services for key populations, and lack of institutional procedures that guide practice. Therefore, in Botswana, when the government made the decision to integrate key population health services in the public health sectors, it was a milestone decision because it increased the availability of services to key populations and increased access for them. So they can go either to drop-in centers, to public health facilities or community clinics, and they will still get the same quality care services. So we started off by adopting a multi-level framework because we recognized the drivers of stigma and discrimination in healthcare settings, and also understanding that key populations face double stigma, stigma of living with HIV and stigma of being a member of the KP community. So to share the lessons from Botswana, these are the key steps that we adopted. At policy level, the government developed the National Strategic Plan to reduce human rights-related barriers to HIV and AIDS, and this was the guiding document that helped accelerate the efforts to end stigma. Secondly, we looked at our guidelines, how we are providing HIV care and STI, and we realized that there was a need to revise the National STI Reference Manual to include the KP Health, and also followed by development of training curriculums. So the STI guidelines, we included information that will help providers to understand unique healthcare needs of key populations, and also provide them with guidelines on quality clinical services for management of STIs, and also integration of HIV, sexual health, reproductive health, and other comprehensive care. With support from FHI 360, the EPIC project that is funded by USAID, we're able to support the government and Ministry of Health to adapt the Health for All training curriculum for healthcare workers that was developed by Linkages. So we did that curriculum, which had two parts. The first part was KP sensitization, and the second part was KP competency training. And the beauty or the strength of this curriculum is that it's also person-centered. So we collaborate with KP communities and they facilitate the KP sensitization training. And being able to bring healthcare providers and members of the community together in one room provides a safe space for them to form a common understanding and understand each other's needs. So we found that very helpful because the KP sensitization also emphasizes on medical ethics and human rights. So that way we saw that it helped healthcare workers to empathize and change attitudes towards key populations. The second part was the KP competency training, which is basically a skills-based training which equips or capacitates healthcare workers to be able to deliver quality clinical services. So your history taking in a way that is relevant, respectful, and competent for you to be able to identify key population needs and do a tailored risk reduction messaging for that individual and different KP types. And that has been very helpful. So far, we have trained more than 500 healthcare providers, and the training is well received by providers. And one of the things that we realized or got from the training is that 50% of healthcare workers were not aware of who key populations are or their unique health needs. And they would recommend, 90% of them would recommend their colleagues for this training. So we thought that this is something that would really help address stigma in our healthcare settings. And we look forward to continuing to roll out these trainings to everyone, including the support staff of the facilities and everyone who is becoming in contact with key populations at service delivery points. And the next step will be, of course, to evaluate the impact of these trainings and the quality of care that we give to the KP communities. Thank you.
Thank you, Dr. Masego, for sharing with us the integration of key population health services in the public health facilities in Botswana. And now moving from Botswana to Ghana, we are going to ask Roberta to describe to us what it is the total facility approach that is being implemented in the hospital you're working in Ghana, and share with us which activities have been the most impactful in reducing stigma and discrimination towards key population attending health services in the hospital you're working with. Over to you.
Thank you, George, for the question. So for my facility, what we did was our main aim was reducing stigma among healthcare workers. So we started with training, and our focus was to train more than 70% of the working force. So we targeted both clinical and non-clinical staff. So we did this through trainings, which was very interactive trainings. And we got management on board, that is management of the facility. And I think that was very helpful. So at the end of the training, each group was supposed to come out with action plans, what they think, if implemented, can reduce stigma in the facility. And at the end of the day, all these action plans were put together. So what helped us? What helped us most was the support of the management team. Then secondly, I would say the proactiveness of the facilitators. So we made the staff to understand why we need to reduce stigma. First of all, reducing stigma is going to increase our client base. More people will patronize our services, and we are able also to generate more. And whilst we are generating more, these incomes will be used to better the living conditions for all of us, or the working condition for everybody. So we made them understand why, or the need, why we need to reduce stigma and discrimination. So that is the approach my facility took. And we also came out with interventions. Interventions we believed, when put in place, can reduce stigma. And one of them is the poster we see on there. So we made different posters, billboards, and we also formed champions team. So with the champion team, we had members of management being part of it, so that junior members won't falter and go strictly by what we did. So we had management team, we had nurses, and we had some non-clinical staff also being part of the champion team. And this team was inaugurated. We had a big opportunity to launch it for everybody to know that our facility has champions team, and we've declared ourselves as a stigma-free facility. So the job of this champions team were to look out for stigma-related issues. So we provided suggestion boxes, we provided telephone numbers with pens and papers, so that anybody who felt stigmatized